So good afternoon, everyone. As Z said, I'm one of the vascular radiologists in Leeds. I'm also the training lead for IR across the Yorkshire School of Radiology. So that's Leeds, Sheffield and Hull. And I've always loved being part of training. When I was a trainee, I had some great trainer mentors. And actually, they really helped me along the way and inspired me and were good role models. And as being a trainer to people, I love seeing people coming through their career, seeing how they progress and then become consultant colleagues with me. And also as part of being a trainer, I think you still keep your hand in, you keep up to date and learn lots of things. And also the main thing is that every day as I'm training, I remember why I enjoy doing interventional radiology. So next slide, please. So I've been asked today to talk about training. And I thought really I should speak a little bit about why I chose to do IR and why I think you should. And to do that, you have to understand what interventional radiology is. Now, I appreciate that you already probably knew quite a bit before you came to the conference today, and you've had some fantastic lectures and workshops. So I'm guessing you do kind of know what IR is, but I will give a summary. And then showing what IR is, talking a little bit about how you get into radiology or IR training, and then what we train with the IR curriculum. So next slide. So to do the talk today, I thought I should tell you, back a slide, spoiler alert. I thought I should tell you a little bit about myself and where I've come from in life. And for those of you who know me, or maybe those of you who don't know me, I've got a bit of a reputation over the last few years for ending up doing things that I said I would never, ever do. So this is a picture of me in my 5th year with my best friend at Nottingham University on our day of graduation. Now, Simon was my best friend. My friends and family obviously saw through this, and it's always said to me that I would end up marrying him. But there was no way I would ever marry him. He was my best friend. So next slide. A few years later in my SHO training career, it turns out that everyone else had been right and I had been wrong. So I ended up marrying Simon. And we were enjoying our training. I was a surgical trainee at that time. He was doing medicine to go and do ICU. So the next thing that I said I would never do, I would never have children. So in my younger years, I'd always wanted a massive family. And then something happened when I went to medical school and I started training, and I absolutely loved it. And my career was my kind of biggest thing. And only 7 years ago, when I was talking to one of my consultant colleagues over a coffee, they said, "Do you think you'll have a family?" And I said, I don't think so. So cue next slide. I would like to introduce you to our 2 daughters, Lottie and Sophie, who are 2 and 5. And I don't know what happened radically within that year, but we kind of changed our minds and definitely don't regret it. And actually, it's worked really well having them as part of our family and doing a career. So I was completely wrong on that. So you can probably guess where we're going with this, really. So next slide. This was me in my 3rd year at medical school, my intercalated degree in pathology, loving my time. And at that point, we had just started doing clinical sessions, and I'd doing general medicine, and I had a session in radiology in a big dark room in the basement of Queen's Medical Centre, sitting up with the old-fashioned radiographs, being asked about chest x-rays and the pathologies that I knew nothing about. It was really embarrassing. And I came out of that session and I said, "Are you ready for it? I would never be a radiologist. It's the dullest and most boring career that anyone could ever have." And I probably don't need the next slide, but we'll have it anyway, to explain that I might have been a bit wrong about that. And yes, here we are sitting here quite a few years on, but it turns out that I'd started on a surgical training pathway, and yet I ended up being a radiologist, and I absolutely love it. So I've learned now that all the things that I say I won't do, I've stopped saying that now, because actually that's quite a bad prognostic indicator for me. So don't worry, I'm not going to tell you about your whether you should marry people or have kids. but I am hopefully by the end of this talk going to convince you to do interventional radiology. So it's definitely not a boring job. Radiology as a whole is really good, but interventional radiology is amazing. What other job or career could you do where you use your diagnostic radiology skills to diagnose and plan treatments for a patient, and then with the support of the clinical teams and making the appropriate decisions, take that patient and do the procedure for them? No day is ever the same in interventional radiology. As you'll have heard through the morning, we do clinics, we do acute CT and MR lists, we do our theatre interventional lists, we're involved in training and research. It's really, really interesting, and there's a massive breadth of it. And this slide shows obviously a plumber, and this is how I used to describe my job to people. I used to say, well, I'm kind of like a medical plumber. I unblock arteries that need unblocking to get blood flow to the right organs, or if a blood vessel's bleeding too much and there's major hemorrhage, then I kind of block it up again to stop that. However, I think that undersells the job a little bit. Next slide, please. So interventional radiology has a massive breadth to it, and I think by now you probably know, next slide, that there are a huge range of clinical specialties that we are involved in. You've already started to understand the different levels of IR in paediatric and neuro, general IR, and we interact with all of the clinical, medical and surgical teams and the acute teams like A&E. I can't really think of a specialty when I was doing this slide that there isn't a procedure that we aren't involved in doing with them. So the breadth and the interest of our specialty is huge. Next slide, please. So I'm going to take you through a typical day, and I should probably start by saying that there is no typical day in interventional radiology. So we have our planned elective lists, and this is a true day. So I came in to do my elective list in the hospital. I knew what was going to happen. I prepared and planned all my cases. And as I was coming in through the door, someone grabbed me and said, there's a patient in resus in A&E. I think they're going to need IR. You probably need to stop your list. So this patient had come in from a major road traffic accident, and we used CT to make a diagnosis of a bleeding internal iliac artery. We were able to plan and reformat the images and work out exactly which branch we thought was going to be bleeding, and then took them round to the angiography suite in order to treat the bleed. Next slide. By localising it, we were able to see the angio image of the bleeding, and next slide, and fairly promptly be able to coil embolise that bleeding vessel and stop the major hemorrhage. So job well done, felt fairly good, a good day. Next slide. So maybe now I could get on with the rest of the elective list. So the next case was a liver tumour, a hepatocellular carcinoma in this case. With imaging and our other specialty colleagues in imaging, we can diagnose these correctly. We can then define the anatomy and look to see which hepatic arteries are supplying that tumour. And then if appropriate for the patient, can bring them to angiography, place a catheter into those branches of the hepatic artery supplying the tumour, as you can see on the first angio image. And there's that big round tumour blast of the cancer. We can then inject particles which have got chemotherapy agent coated on them straight into that tumour. And that has the dual-fold focus of actually giving chemotherapy agent to the tumour, but also blocking off the blood vessels, as you can see on the second image, showing there's no further supply to that tumour. Next case. And then the usual thing happens just when you think now the day's back on track. I'm going to get on and do my next elective case. There's another patient who's come into A&E resus. I'd like to say that this is a particularly bad day. It doesn't happen like this every day. But this patient had come in with abdominal pain and a low blood pressure. And you can see on the scan there that they've got a large abdominal aortic aneurysm, and all that stranding around where the arrows are shows that it has ruptured. We're able to use CT to make a diagnosis that that's what the patient has, but we can also plan and look to see if the anatomy of that aneurysm is suitable for a radiological endovascular repair. Next slide, please. So I came from a surgical background, and I'm used to seeing big open wounds, But abdominal aortic aneurysm surgery is major surgery. Aside from the huge scar, the recovery times are long, and some of these patients are quite frail. They've already had an incredible insult to their body. So rather than having to do that to a patient, next slide please, wouldn't it be better if the operation field looks like this? And we are able, with interventional radiology, via central keyhole techniques with just access from the arteries in the groins, to reline the whole of that aorta with a graft and to stop the bleeding and to close those holes in the arteries ourselves now with our percutaneous vascular access closure. In an elective aneurysm, patients can be done on the same day and go home. With a rupture, that's a bit less likely, but they can go home within 48 hours, which is a lot less time than it may need from open surgery. Next slide. So as you've already got a feel, Alex has been an excellent talk and Tony earlier. So I'm coming a little bit from a vascular skew purely because that's what my job is, but that isn't just what interventional radiology is by any means. So we have what we term interventional radiology, which is encompassing vascular, non-vascular, interventional oncology. We then have the other subgroups of neurointervention and paediatric intervention. And the training pathways are similar, but just a little bit different from the peds and neuro. And I know that Alex and Tony have already spoken. So when I'm talking about training today and some of the little bit more details, it's a little bit more on the kind of general IR pathway, but it's all applicable. So next slide. So hopefully, if nothing else from this talk, you will understand that IR is a fantastic specialty. And if I teach you nothing else, please don't make the mistake that I made when I said, radiology is really boring, I will never do it, because I just didn't know enough about it. So if you'd like to do IR, entry to interventional radiology is currently via the general radiology training scheme. There's a little bit of a spoiler alert that I've been given permission to tell you, and that is that hopefully in a year or two, there will be some numbers across the UK where there'll be direct entry to IR training for those people who pretty much know that they want to do it from the start. But we will have to watch this space to see how things progress with that. As I said, entry to radiology currently is via the general radiology scheme, and it's via a national recruitment process across the whole of the UK. So you apply to come and have one interview, and there's a large panel of us who interview for all the training or potential trainees across the scheme. Everyone's ranked to interview, and then according to their rank and preference of where they'd like to be in the country, they get allocated appropriately across the country. At the moment, entry to radiology comes via two kind of ways. First is after successful completion of foundation year training, or some people go on to do other training specialties, as I did a while back though, and come from general surgery, medicine, anaesthetics, A&E. It doesn't matter. At the moment, those two routes are to come in. The training for general radiology takes place over 5 years if you have successful completion of exams, which I'm not going to go into in depth today, and all the other competencies along the way. IR now, it's recommended that you train for a 6 year, and I'll come on to that a little bit later about how you get that 6 year of training. But at the end of your time of training, you're given a certificate of completion of training, and this allows you to then apply for your consultant post. Next slide, please. So the first thing to say about IR training is you have to remember that you're coming in to train as a general radiologist as well as an interventional radiologist. And you have to realise that the diagnostic skills involved are just as important. So to be able to diagnose and plan an intervention is just as important, if not more, as putting our wires and catheters into the right places. So at the moment, and probably for the future, the training in radiology for the first 3 years is looking at gaining core radiology skills, and that is in plain film, CT, MR and ultrasound through different subspecialties in radiology. Then the last 3 years of your training are spent looking in your subspecialist area in IR, gaining the level 1 and the level 2 skills that are needed to give you your competencies to become a consultant. Next slide, please. So the first 3 years, if we look at those, the first year involved is usually getting some of your basic competencies and getting your part 1 exam, which is physics and anatomy, enough said. Then, once that's been achieved, you then do a checkerboard style attachment. And although this will vary from training scheme to training scheme, you're still going through the different subspecialty areas to make sure that you have the grounding in radiology in those areas. Next slide. If you're coming into radiology and you know that you'd like to do interventional radiology, or you think you'd like to do it on a general training scheme, it's really, really important that you get exposure and experience as soon as you possibly can. I can't really stress this enough. It's good to get an idea of what the job involves. And there are different ways of doing this. One way is to get your IR attachment as soon as possible, but obviously there are other trainees on the scheme and this isn't always as easy as it says. Having been standing up for the TPD role for a year, I realised I couldn't quite put everyone in the IR training slots that I wanted to. The other way is to try and get a session of IR training within your weekly training plan, no matter which specialty you do. And I did this as a trainee coming in from year 1. But now there is a more formal way of doing it. And we're doing pilot schemes of enhanced IR training. And this is taking place across the UK. And what this does is it tries to incorporate a session of IR training in whichever job you're doing after you've got your part 1 exam. So in years 2 and 3 usually. The aim of this isn't to give you every single skill and bring you at ST4 as a fully qualified interventional radiologist. What it does is it gives you a realistic insight into the job. You're able to see if you enjoy it, if you think you have the skills and the hand-eye coordination, and it gives you a bit of time to develop that because no one's going to come in being able to do it from day 1. And the other thing it does is it just gives you a regular chance to be able to develop your core competencies in vascular access or non-vascular access and the catheter wire skills that you need to then build on the more complex procedures. So it means that when you're at ST4, you've probably already done quite a few cases and you feel quite comfortable in the lab, and then you can really get on with your training. Next slide, please. So as I said, in the interventional radiology world now, we try and have 6 years of training. So the advice I give people is, if you're coming in, or the way you do it, if you're coming in, when you get to the end of ST3 year, you kind of declare your interest in interventional radiology. And you register that interest with your training program director, who then tells the college that you're going to be following the interventional radiology training curriculum, which you can see there, which is about to be changed, I think, at the end of August this year. And what that means in real life is that curriculum has competencies that you need to achieve in IR. And if you're coming on the general IR pathway, that's non-vascular and vascular, irrespective of whether you are going to end up as a vascular or non-vascular radiologist if you're going to distinguish them. So it means that you started off at ST4 getting all those core competencies. Now, ideally, because you've only got 5 years of training at the moment, you need to find a way of getting that 6th year of training. In the UK, in each of the training schemes, there are a small number of what they call an IR number. And what that means is you go to a competitive interview usually, and if you're successful, then you are allocated a 6th year of training. You don't really change your training number. It just means that you have that allowance to be able to do your 6th year. And if you complete that successfully, then you'll get a dual CCT, one that's in general radiology and also IR. And that's what I ended up doing. However, you can still do post-CCT fellowships. So what that looks like in real life is that you do your 5 years of general IR training, you get your CCT in general radiology, and then you'd go and get your 6th year elsewhere in IR. It's not that you can't do that, and I know Tony and Neuro, they probably kind of were suggesting that people should do it. In general IR over the years, We found it's a little bit harder, so there are less UK post-CCT fellowships, and getting abroad has become a bit more competitive. So it's not that you can't, but you have to be organised if you're going to do it that way. So it's just getting a little bit more difficult, but it's not a no. Next slide, please. So if you do the IR training pathway in years 4, 5 and 6, how we run it locally, and to be fair in a lot of the places, is that your years 4 and 5 are spent doing core IR training. And that means getting your core skills in non-vascular and vascular procedures. And you can tell that a little bit more to one way or the other. And then in year 6, it's spent getting your higher skills, those that are going to help you go to the consultant job that will be suiting you and that you're going to go to. And that might be that you have more IO training, so interventional oncology training, or that you focus on the vascular pathway, or that you focus on a non-vascular pathway. And through each year, at the end of each year, you have something called an annual review of clinical progression, or an ARCP. And what that is that you meet with the trainers and they look through your e-portfolio, which you will have diligently collected lots of assessments over the year. And that's just proof that you are doing imaging, that you're able to make the right diagnostic choices, and that you've been doing some procedures. As a first year trainee in IR, when you get the box ticked to say that you need direct observation for your procedures, that's a good thing. It's not a bad thing. And when you start, someone should be teaching you. Your aim is that when you're leaving at year 6, that then you're competent to do it on your own. And that's showing the progression of your training along the way. Next slide, please. So I was asked a little bit about portfolio building, but there's an excellent session for medical students and for doctors this afternoon. So that bit's going to be very brief from me. But my top tips are, if you're sitting here today, whether you're a medical student or a doctor, and you'd like to do IR, then talk to us. So talk to trainees and talk to consultants. I'm more than happy to be contacted, as are most of my colleagues. But it's good to hear what the job's like and any advice that they would give you. It's really important to get experience in it. So in a medical school, you can get involved. If you're doing a radiology attachment, come along, ask to be involved in the lab, come and see what we do. We also run projects and teaching sessions. And if you're coming in your foundation year, then it's good to get a clinical attachment in radiology, even if that's just a taste a week. And that's to come and talk to people and see what's going on. There are lots and lots of projects to get involved in, lots of research projects, lots of teaching and training. So please ask us. And by doing this, it gives you the experience that you'll need. It also gives you some very good lines on your CV when you're applying for radiology and shows that you've had an interest from an earlier stage. Next slide, please. So hopefully that's been enough of an overview of training. As I said, I'm very happy to be asked questions, but if we go to the next slide, my overall summary is, if you take nothing else from this talk, I want you to know that it is a top career. Do not make the mistake I made. 6 years of training is what we'd recommend, and currently the entry is via general radiology training. That may be changing, but get IR experience as soon as possible and come and talk to us. Next slide, please. Happy to answer any questions. I will stop talking.
Thank you so much, Dr. Flood, for that. That was inspiring. We have quite a few discussion points just on from the chat.
Okay.
About the difference from, YiiRS has a direct entry to VIR for medical students for several years, and it's been very successful. So we're hoping that the same will happen for UK and Europe. And we have a question, which is, are we at a disadvantage if we do not do any specialty training, for example, IMT or CST, prior to applying for clinical radiology?
So my answer to this has definitely changed. And the simple answer is no, I don't think you are. I used to, because I come from a very long training background of doing the old system with SHO years, I used to have a very skewed feeling that it was good to have done something else beforehand. And I think it helps clinically to have had some experience beforehand. However, radiology is a huge specialty, and I came in from surgery, and in radiology there's an awful lot of paediatrics, general medicine and other bits and pieces. So it helped me in a very discrete part. So I don't think there's a disadvantage to coming from the kind of foundation year. Equally, there's no disadvantage if you've been and done something else, if that kind of answers the question. I think the main thing is that you need to know a little bit about radiology and come and get some experience. But, you know, there's kind of benefits from both. And we see that in our trainees coming through. We still have a real mix of trainees, and neither side distinguishes them. They're all very, very good, and it doesn't seem to matter where they've come from.
Great, thank you. And I think you might have answered this question in your talk already, which is, what if you have studied medicine, how long does it take for you to study IR? So I think it was a question 10 minutes ago, so I think you might have answered that. So I'll move on to someone who's asked, let's say we get to F2 but are quite keen to get a number for IR specific specialty training, in brackets, if it becomes its own separate training pathway. Would it be better to take an F3/delay training, wait and hope that some number get put out, or just go straight into ST1 clinical radiology?
So I would suggest that if you want to do it and you know you want to do it, I would get stuck in and I wouldn't delay anything. So the training pathway at the moment, even when and if these direct to IR numbers come out, that we're not going to change it all to that system immediately. You can still come in via the general radiology pathway, and we're very much mindful of that. And I've got trainees on the general radiology pathway at the moment who I know want to do IR, who I'm making sure there will be allocations for as they're coming through. So at the moment, it's too early days to delay. So until that system is up and running fully, there will still be a dual way of getting into IR. So for that reason, I wouldn't delay anything.
Great, thank you. And the last question is, with Leeds being an academy, how do you think this compares to traditional schemes?
Oh, I'm going to be very skewed on this. I think either way, all the training streams across the UK are very, very good. I enjoy the academy. I think I was about the second or third year in when the academy had opened. I didn't particularly have a sway either way at that time, but the teaching that I've seen coming from the academies with set days from years 1 to 3, it's really, really good. And the support I see from the 3 academies that are in the UK are very, very good. But equally, you know, I wouldn't say that the other training schemes aren't, because the teaching occurs then in-house and there's still provision for the Part 1 exams in all the other centres. So I think it's probably more about where you want to be.
Great, thank you very much. And thank you again for sharing your expertise and your story with us. It's really inspiring. So yeah, it's a great honour to have you. Thank you.
Thank you very much.
Thank you, Karen.
Bye then.
Bye.